आदित्य, आपका क्या हुक्म था? मैंने सुना नहीं।
मैम हुकुम नहीं, आपने सजेस्ट किया था, जो वही कंफर्म किया था पंकज सर को। आपने कहा ना मैम कि यू विल इंट्रोड्यूस द यंग लेडीज एंड he will
Yes.
introduce the topic. Yes,
Perfect.
that's
Perfect.
what I conveyed. Yes, ma'am.
Okay. Thank you.
Sir, I am starting the webinar. Very good evening and welcome to one and all. I am Momita from Planet, the designated session assistant for a seamless experience. And Planet is India's most trusted and widely used digital platform with multiple enriching services exclusively for doctors. Planet is very proud to be a digital platform for this event organized by Indian Society of Pediatric Nephrology. And the topic of today's session is Module 5, uh, congenital disorders of kidney and urinary tract. So let's begin today's session, for which I would like to invite Dr. Jitendra Meena sir to take over. Over to you, sir. Thank you so much.
Thank you, Mamita. So good evening, everyone, and thank you again for joining us today. So before we begin with the webinar, we'll have the pre-test, and the link for pre-test I'll be sharing in the chat box. Mamita, you need to make me co-host, please. I can't
Okay,
say it.
Okay, sure, sir. Okay, sir. Please check.
So participants, I've shared the link in the chat box. You can attempt pre-test from there. You'll have 10 minutes to do this quiz. After that, we'll begin with the main webinar. So those of who have joined late, I have said the link for pre-test and chat box. You can attempt from there. So it's already 15 minutes past 7 p.m. So we'll begin with the main webinar. So topic, this is the last webinar in module 5, which was congenital disorders of kidney and urinary tract. So today we'll be discussing about the overall approach of cystic kidney disease. And today's session will again be moderated by Madhuri Kanitkar ma'am and Pankaj Hari sir. So ma'am and sir, over to you for further proceedings.
Thank you, Jitendra. Good evening, everyone. I, along with my co-chair, Lieutenant General Madhuri Kanitkar, will be moderating this session on cystic kidney diseases. And this is the last webinar among the series of the TACUD that we have been discussing every week. Cystic kidney diseases are important because they are an important cause of CKD in childhood, particularly in young children. And majority of these illnesses are inherited and have a genetic basis, which has been identified over the last 20 years now. For most of the disorders now, we know the genetic defect. And therefore, genetic testing also allows us to do the precise, to make the precise diagnosis of the cystic kidney disease in majority of children. That also helps in prenatal counseling and also when you are going for transplant. In addition, if you think that cystic kidney diseases are untreatable because you can't change the physical anatomy of the kidney, There is a drug which has become available in adults. It's been tested and it has shown to reduce the progression of disease into end-stage kidney failure. And this is for autosomal dominant polycystic kidney disease, tolvaptan, and it's also been tried in adolescents. So we have some therapeutic options apart from the genetic diagnosis, and these are things which are new, and these all will be discussed in today's webinar. So now I would hand over the session to my co-chair, Dr. Madhuri Kanetkar, who shall be introducing the speakers.
Thank you so much, Dr. Pankaj, and thank you, Jitendra and Dr. Aditi, for this module, which has been really interesting, taking all the delegates through those 6 sessions from kidney, UTIs, bladder, what have you, and now we've come to the cystic diseases. We have 2 dynamic young ladies to give you this talk today. And the topic, as always, is divided into an approach for the management and then revised through case discussions. So we straight away start off with Dr. Christy Thomas, who's an assistant professor of pediatric nephrology at the SAT Tiruvananthapuram. Christy, can you start your presentation? It's all yours. Yeah, your voice is not heard, Christy. Oh, you know something? You may have to log off and log in because I don't see a voice input at all. Normally we see us, yeah, now I can see it. So I think there's something loose. It came and went.
Okay.
Yeah, now it's there. So,
Okay.
yeah, now you're good. Yeah.
So I will start.
Yeah.
So at the outset, I would like to thank the organizers and I would like to thank the chairs for the nice words. So I will start the topic. My topic is management of cystic kidney disease. So cystic kidney diseases are one group of disorder. Here, the patient often comes to you with an image-based diagnosis. They will be carrying an ultrasound saying that the patient is having renal cyst. So sometimes you may see a patient with suspected cystic kidney diseases like AD, PKD, or PKD, and you are after the radiologist to, is there any cyst in the kidney? So as correctly mentioned in one webinar, all cysts are not equal. We need to find which one is alarming, which one is trivial. History, clinical examination, investigation, imaging may help us to differentiate among different types of cystic kidney disease. So this topic is vast, but my aim will be to familiarize you with the common cystic kidney diseases and prime you on some of the hints that may lead to definite diagnosis. So how will you identify cyst in the imaging? Cysts in ultrasonography will be seen as anechoic structures. These will be like a black structure. In the extreme left side, you can see the kidney with altered corticomedullary. There is no corticomedullary differentiation, and these black round structures are the cysts. In the middle picture, we can see multiple rounded cysts, and in the right side, you can see very small cysts with post acoustic enhancement, like which may mimic a nephrolithiasis. Conventional USG or the high resolution USG may be used to detect the cyst. And in few setting, you may even have to go for an MRI or CT. So how do these cysts develop? The cysts develop due to dilatation of any part of the nephron. It may be a glomerulus, any part of the tubule. It's like loop of Henle, the collecting duct. Any part of the tubule can dilate and form a cyst. What is the cellular level pathology? Here, there are many pathologies out of this. I would like to mention 2, which include the cellular proliferation and the loss of cell polarity. Usually, the tubules elongate along the direction of the tubule. When they lose the cell polarity, they may elongate perpendicular to the direction of the tubule and leading to increase in the diameter or the dilatation of the tubules. These at the cellular level leads to tubular dilatation. And what happened at the organelle level, the primary culprit behind this is formation is the primary cilia. Primary cilia is otherwise called the non-motile cilia. It acts like a sensory organ to the cell. Here we can see the parts of a primary cilia. It has got a axoneme, ciliary axoneme, basal body, and centrosome. If any protein get mutated any part of this structure or the primary ciliary dysfunction set in, here we can have the development of renal cysts. Hence, the renal cystic diseases are otherwise called ciliopathies. The ciliopathies in kidney can cause cellular proliferation, tubular dilatation, interstitial fibrosis, and tubular atrophy. The phenotypic spectrum of ciliopathies are not limited to the kidney. If other organs, ciliary dysfunction occur in other organs, it can lead to manifestations like retinitis pigmentosa, anosmia, liver fibrosis, obesity, diabetes, situs inversus, bone changes, mental retardation. So the manifestations are wide spectrum of manifestation can occur in case of ciliopathies. We have seen the pathology and pathogenesis, so we should be aware of what are the diseases that we should be looking for when a patient comes with cysts in the kidney, which include the ciliopathies. As I said already, they are inherited and monogenic, which include the autosomal dominant polycystic kidney disease, autosomal recessive polycystic kidney disease, nephronophthosis spectrum disorders, the TSC, von Hippel-Lindau, orofacial digital syndrome, Beckwith-Wiedemann, then have glomerulocystic kidney disease, autosomal dominant tubulointerstitial kidney disease. Occasionally, we can see acquired cysts in case of a patient with advanced CKD, or if a patient is in dialysis, or a patient with electrolyte imbalance like hypokalemia. You may all be aware of multicystic dysplastic kidney disease, where the entire kidney may not be functioning. Then you have dysplastic kidney disease due to monogenic caput, or acquired cysts may occur in case of obstruction, like PUG obstruction, or in case of posterior urethral valve, or in case of reflux diseases. Then dysplastic cysts may occur in case of lymphatic pathologies or vascular infarction or part of infection, metabolic diseases where the abnormal metabolite get accumulated and later leading to cyst formation. Then you have medullary sponge kidney. Occasionally, benign or malignant tumors can present with cystic lesions. And even after detailed evaluation, some may remain unknown with unknown etiology. So from this, we will go to our first disease, the autosomal dominant polycystic kidney disease. Autosomal dominant polycystic kidney disease is characterized by expanding cysts in any part of the nephron. So glomeruli, tubule, any part of the tubule can get have dilatation of the dilatation and leads to cyst formation. So the renal cyst will be there, may be there in case of subcapsular area, cortex, medulla, corticomedullary, any part of the kidney can have cyst in case of ADPKD. Here, the inheritance of is autosomal dominant, so family history may be there. Here, as the cyst size increases, the kidney size also increases, and you may get a very large kidney. Here, the renal manifestations include the patient can have decreased renal function, hypertension, proteinuria, urinary concentrating defect. In addition to the renal manifestation, many other organ systems can also get affected. You may be aware of the liver cyst. There can be pancreatitis, diverticulosis, bronchiectasis, cardiac valvular defect, mitral valve collapse may be there in 12% of kids. Pericardial effusion may be there, and intracranial aneurysm is also another manifestation. If the patient is having a family history of intracranial aneurysm, they are at high risk of aneurysm formation. So other than that, patient may present with the complications in the cyst. It's like cyst infection, hematuria, nephrolithiasis. A small percentage of kids can have renal cell carcinoma. not kids, it's seen in adults. Sorry. So when will you suspect ADPKD? ADPKD, you have a family history, parental screening should be done. Up to 90% of patients may have a history. When family screening or the patient may, parents may come up with a diagnosis of ADPKD. What are the other autosomal dominantly inherited cystic kidney disease, which include autosomal dominant tubular interstitial kidney disease, especially HNF1 beta is a close DD. And clinical features, usually non-specific patient may present with the symptoms of hypertension or vague abdominal pain. Usually patient comes with ultrasound done for any other non-specific symptoms. So radiologically, patient can have normal to large size kidneys. Cysts are relatively large compared to other cystic kidney diseases, and hepatic cysts may be there in the patient or in the parent. So the genetics, the main two genes are the PKD1 and PKD2. Most 85% is by PKD1. And in case of PKD1, PKD1 has more severe disease than those affected with PKD2. And one thing you should be knowing is that if the patient is having a truncating PKD1 mutation, the patient will have advanced disease and early ESRD. There are many genes associated with the liver and kidney cystic disease. I would like to mention two more, GNAB and DNA JB11. So when should be sending a genetic testing in case of an ADPKD? If the patient is having no family history, if the patient is having early severe disease, familial heterogeneity, atypical imaging finding, or we are suspecting the disease is closely mimic other ciliopathies, syndromic presentation. Before donation and pre-implantation also, it's suggested to do genetic testing. We can send a clinical exome sequencing. If we already have the previously affected gene, we can send a sample, or when we are suspecting large deletion, we can ask for MLPA, or you can send the PCR. So one thing that come in the last decade is the concept of rapid progress in case of autosomal dominant polycystic kidneys. As you have rightly guessed, rapid progressors will have early progression of renal dysfunction, and they may have early ESRD. So when will you call a patient rapid progressor? The parameters that we look include early renal dysfunction, early rapid increase in rapid increase in the kidney volume. If the patient is having early onset of hypertension or urological complication, very large kidney in the adults, or if the patient is having a PKD truncating mutation or a family history of RRT below 58 years also, there are very different criteria. So most of these criteria will look into the above mentioned points to say whether the patient is rapidly progressing or not. In case of rapid progressors, we have a disease modifying agent which was approved by FDA, which is a V2 receptor antagonist. The initial drug is a tolvaptan. What is the mechanism of action of tolvaptan? The cyst proliferation and fluid secretion is mediated by the cyclic AMP. Cyclic AMP production in these renal tubules are regulated by arginine vasopressin. So V2 receptor can block the step and prevent or control the cyst proliferation and fluid secretion, and they can sort of halt the progression in case of a rapid progresses. While giving it all, it's approved in adults only. It's as of now, it's not approved in kids, but it's an aquaretic agent. So free water loss may be there. Patient can have polyuria. Another important side effect is the hepatotoxicity. In the initial period, there was concern whether the efficacy will be persistent over the years or not. So now we know the rapid progressors. In pediatric cases, even if it is rapid progressor, as of now, tolvaptan is not recommended by the guidelines. So we have to go for the supportive care. These include the lifestyle modification, weight management. We have to give the balanced diet. Salt should be restricted. Fluid, we have to ensure proper fluid intake. There are many trials with water therapy where the urine osmolality kept less than 280 to prevent the again arginine vasopressin secretion. Then we should control the blood pressure using a first line agent that should be preferred, the AC inhibitors or ARB. And we should control the proteinuria. If the patient is having acidosis, we have to supplement with the bicarb. Essentially, the management is supportive. So from that, we will jump to the next disease, the autosomal recessive polycystic kidney disease. Autosomal recessive polycystic kidney disease is a prototype of hepatorenal fibrocystic disease. Here, the liver and the kidney may be affected. So, as it's autosomal recessive, the family consanguinity may be there. We have to ask there any siblings are affected. In ARPKD, around 50 to 70% patients can have severe neonatal disease. And this is characterized by abdominal distension. Abdominal distension may be due to large kidneys, or maybe hepatomegaly may be there. If the portal hypertension has set in, there may be splenomegaly, ascites may be there. In the perinatal period, lung issues can occur because of severe oligoamnios. Lung hypoplasia may be there, or there may be an abdominal distension, or a pneumothorax may be there. Hypertension is a complication of severe neonatal when patient is having severe neonatal disease. In unsuspected cases of ARPKD, hypertension may be missed, and the patient may present with cardiac failure. Or patient may present with early hepatic or renal complication. About the hepatic complication, patient can have congenital hepatic fibrosis, Caroli's disease, and the complications of hematemesis, portal hypertension, hypersplenism may be there. Renal patient can have ESRD or CKD of various stages depending upon the renal involvement. So how will you see ARPKD kidneys in the ultrasonography? They are usually large kidneys with small cysts. In ARPKD, the cysts are formed in the collecting dust. So in imaging, the cyst will be appearing in the medulla or in the corticomedullary area. And one typical finding is we may see an elongated radial arranged cyst in ARPKD. And in ultrasonography, we may even see congenital hepatic fibrosis or features of Caroli's disease. What is the molecular level finding? We can see the mutation of PKHD1 gene, or which we and the next gene recently described is DZI-B1L gene. So when we are suspecting an ARPKD in an antenatal scenario, we may have to repeat the ultrasound around 2 to 3 weeks, and we should be looking for poor prognostic marker, especially markers for pulmonary hypoplasia in the immediate neonatal period may be stressful if the patient is having pulmonary hypoplasia. So these markers include severe oligohydramnios in the second trimester, large kidneys with oligohydramnios, or if the patient is having a lung volume less than that for the gestational age, that may suggest the patient is going to have a pulmonary, have a stomy course in the neonatal period due to pulmonary hypoplasia. Postnatally, obviously, we have to look for the respiratory status due to pulmonary hypoplasia, diaphragmatic compression, or due to the pneumothorax may be there. Facial dysmorphism may be there. Neurocognitive delay, inguinal hernia, cardiac issues may be there. The 1-year survival is described as 80 to 85%, and 10-year survival is around 82%. In the immediate neonatal period, two distinct complications that we should expect include severe hypertension, and 30 to 75% may have severe and may present with congenital cardiac failure, and another is severe hyponatremia. The euvolemic hyponatremia may be there in few kids. So in this kit, in addition to the renal management, we have to have some hepatic hepatic involvement should also be managed, which may include the manifestations include again congenital hepatic fibrosis, portal hypertension may be there. Patient can have cholangitis, which may present with fever, raised GGT and ALP. And if the patient is having recurrent cholangitis, we may have to go for antibiotic prophylaxis. So liver is affected, the fat-soluble vitamin deficiency should be anticipated and we should be looking for. The patient is having portal hypertension, surveillance and endoscopy of the varices should be done. EVLO and beta blockers may be given as prophylaxis if needed. We may anticipate a splenectomy, even though it is not advised if the patient is going ahead with the liver transplantation. So vaccinations before splenectomy should be complete. And if the patient is having sick TB and hepatobiliary disease, also deoxycholic acid can be given. From this, we'll go to the third ciliopathy. It's a nephronophthosis spectrum disorders. They are inherited autosomal recessively. So family history, sibling may be affected, consanguinity may be there. It's a tubulointerstitial nephropathy. It's the most common cause of ESRD in the first 3 decades of life. Out of the many nephronophthosis, NPH1 mutation causes maximum number of nephronophthosis spectrum disorders. Since it is a tubulointerstitial nephropathy, renal manifestations include the polyuria, polydipsia with renal dysfunction. Early anemia may be there. Unlike other causes of CKD, patient can have hypertension is relatively late, except in ESRD, it's usually not seen. And in infantile form of nephronophthosis, hypertension is early. Proteinuria is also late, except in specific mutations. I've already said about many phenotypic spectrum of ciliopathies that we may see as an extrarenal manifestation of nephronophthosis spectrum disorders. Eyes, central nervous system, skeletal system, liver, heart, many of the systems may be affected with different disorders. So how will you classify nephronophthosis spectrum disorders? We can classify depending upon the age of reaching ESRD. If the patient is reaching ESRD below 2 years of age, we can call infantile nephronophthosis. Juvenile nephronophthosis and adolescent onset nephronophthosis are other 2 classification. And next classification is based on the gene and the variant affected. Around 26 NPHP genes are there, and around 80 nephronophthosis spectrum disorder genes may be there. We can also classify depending upon the associated clinical features, which may include the Joubert syndrome, Sennel-Loken, Meckel-Global-Cogan, Boyce's, Saldino-Macer, based upon whether liver, kidney, eyes, heart, which system is affected. There are many named syndromes associated with nephronophthosis. Here, this is ultrasound of the liver, which is showing central dot sign. This is intrahepatic biliary radical dilatation associated with hepatorenal fibrocystic diseases. We already seen one example for hepatorenal fibrocystic diseases was ARPKD. In nephronophthosis also, we can have hepatorenal congenital hepatic fibrosis and keralysis. Here we can see the patient is having polydactyly. Diseases like Bardet-Biedl syndrome is associated with polydactyly. In the fundus, we can see features of retinitis pigmentosa. Sennel-Loken syndrome is associated with nephronophthosis and retinitis pigmentosa. In the MRI image, you can see elongated cerebellar peduncle may be a case of Joubert syndrome. And in the X-ray, we can see the situs inversus. So it usually seen in NPHP 2 or 3, infantile nephronophthosis. So from there, we will go to the autosomal dominant tubulointerstitial kidney disease or ADTKD. This have an autosomal dominant inheritance, but spontaneous mutations are common. So family history may not be there in all. ESRD is delayed usually around 25 to 70 years. As it is a tubulointerstitial kidney disease, there is no delayed hypertension, minimal proteinuria, microscopic or no hematuria. Hyperuricemia is a distinct feature of ADTKD. Here, imaging, you may say corticomedullary sins. Genes involved include HNF1 beta, UMOD, MUC1, REN, and SEC6-1A1. Pathology, you may see tubulointerstitial damage, globular basement membrane damage, tubular dilatation, and necrosis. The one disease that should be aware among the ADTKD include the HNF1 beta related diseases, hepatocyte nuclear factor 1b related diseases. These have autosomal dominant inheritance with many spontaneous mutation. The manifestation, the kidney includes cystic kidney dysplasia, hypodysplasia, cortical cyst, glomulocystic changes. In prenatally diagnosed hyperechoic kidneys, it is one among the it's a most important differential diagnosis. So when you are seeing an hyperechoic kidney, especially large kidney, in a antenatal ultrasonography, you should always think that it's maybe an HNF1 beta related disorders. There are some distinct extra renal phenotypic features include the MODY or maturity onset diabetes, genitourinary abnormality, acute hyperuricemia, hypermagnesemia, and association with autistic spectrum disorders. So, multicystic dysplastic kidney disease, it's one among the common disorders that we see in practice. The incidence is, prevalence is 1 in 3,600 to 4,300 live birth, and it's more in boys and it's more in left side. Here we can see multiple cysts of varying size which are non-communicating and disorganized, and you may not be able to see, usually may not be able to see normal renal parenchyma. We assume that the kidney is not functioning here. Usually the entire kidney is not functioning and there may be segmental cystic dysplastic changes occasionally. You may think that we need only one kidney, but the other kidney may be affected. 30% can have abnormal contralateral kidney, 15% can have extra renal abnormalities, risk of hypertension is there, minimal risk of malignancy is there. Involution of the MCDK, multicystic dysplastic kidney, occurring around 53% cases. So we need to do an ultrasound monitoring if the we should look for the involution of the multicystic dysplastic kidney and also look for the contralateral hypertrophy, whether it is hypertrophy of the contralateral kidney is there or not. So we have seen many cystic kidney diseases. So I will summarize with how will you identify the individual disease. This is like a revision what we have already seen. So we will ask the history for inheritance, whether the patient is having autosomal or recessive pattern of inheritance. If it's not there, we will go to the next step. If there is physical examination, is there an extra renal manifestation? Then we'll go to next step, the ultrasonography. And if above 3 are not able to find the or find the individual disease, we may often go to genetics, or to confirm or to prognosticate, we may have to go for genetics. While seeing the individual disease, we should be also looking for whether the cysts in the kidney are secondary. Is there any structural or functional obstruction, or is there any features of dysplastic kidneys, reflex? Is there any primary tubular disease? Is it an RTA or Bartter with severe hypokalemia leading to renal cyst? Or is it an acquired cystic kidneys due to, is a patient in RRT and later develops cyst? These things also you should be keeping in mind. While seeing the ultrasonography, you should be keeping in mind these things. Large kidneys are usually seen in ARPKD, ADPKD, HNF1 beta, nephropathy, and infantile nephronopathy spectrum disorders. So small kidneys, usually nephronopathy means shrinking kidneys. So nephronopathy kidneys are small. ADTKD, dysplastic kidneys are usually small. In in normal kidneys may be seen in ARPKD, ADPKD, nephronopathy, and ADTKD. And the cyst location will depend upon the part of the tubule which is affected. If the entire nephron is getting affected, diffuse cystic change, the cyst location can occur in any part from subcapsular area to cortex medulla, that occur in ADPKD. ARPKD, usually the collecting ducts are affected. So it may be seen in, already mentioned, medulla or in the corticomedullary area. ADTKD also collecting ducts are affected. So the distribution may be depending upon the area of the nephron which is dilating. Cyst configuration, usually we are expecting a rounded cyst, radially arranged. Elongated cysts are seen typical of ARPKD. Complicated cyst with calcification of the cyst, hemorrhage of the cyst, these usually occur in autosomal dominant polycystic kidney disease. The extrarenal manifestations like hepatic cyst may be there in ADPKD. Congenital hepatic fibrosis of Caroli disease may be there in hepatorenal fibrocystic disease like ARPKD or nephronopathy. So my take-home message is that cystic kidney diseases are ciliopathies due to primary ciliary defect. They can have heterogeneous presentation with many extrarenal manifestations. A detailed clinical radiological evaluation is needed in all, and a genetic evaluation may be needed in many. Overall outcome management depend upon the type of the disease. So with this, I will like to conclude. Thank you.
Thank you so much, Christy. All the participants will agree that, I mean, it's such a diverse, a presentation of diverse situations in the cystic, from seeing cysts in the antenatal period, hyperechoic kidneys in the antenatal period, to a presentation of an isolated cyst to CKD, or then, when they just nephronophthisis, where you really see those children with short stature, anemia. So it's such a vast thing that it gets very difficult to assimilate. So we put them all together from the etiological and genetic kind basis, and for the management purpose. So to understand that a little better, we have Dr. Devalina Dasgupta, who's the assistant professor at the Division of Pediatric Nephrology at the Institute of Child Health, Kolkata. And she will bring us some clinical case scenarios and their management. Devalina, it's yours.
Thank you, ma'am, for the nice introduction. And I would like to thank the organizers for giving me this opportunity. So after the excellent overview of the various cystic kidney diseases by Dr. Christie, I would like to discuss certain cases. So our first case is an 8-year-old male child who had presented with abdominal pain, and that's why an ultrasound was done. That incidentally showed presence of a cortical cyst in the right kidney. The bilateral kidneys were otherwise normal in size. There was increased cortical echogenicity, and a cortical cyst measuring 1.2 centimeter was found in the right kidney. The child did not have any polyuria, polydipsia. It was a well-thriving child, and the office BP records were also normal between 75 to 98 centile. There was no organomegaly, no extrarenal manifestations. RFPs were normal, and the urine routine showed 1+ proteinuria. So what should we do next? So in a child who is presenting with an incidentally detected cortical cyst in the right kidney, well thriving with no hypertension, normal RFP, only with urine routine showing 1+ proteinuria. So we should go for a detailed family history. So in this child, we found that this child was actually born to a non-consanguineously married couple. He was first in birth order. And his father, who was 32 years old, was hypertensive. And the paternal grandfather, who is at present 62 years old, had end-stage kidney disease that was diagnosed 4 years back and is currently on intermittent hemodialysis. So ultrasound of the family members were done. The ultrasound of the father showed bilateral enlarged kidneys with 4 cysts in each kidney, largest being 1.3 centimeters. The paternal grandfather's ultrasound also showed bilateral enlarged kidneys with multiple cysts bilaterally, more than 1 centimeter. And the ultrasound of the mother and the paternal uncle were normal. So according to the radiological criteria for diagnosis of ADPKD, if the family history is positive but the genotype is unknown, this criteria was actually formulated by Pei, and it says that in the age group of 15 to 39 years, if there are 3 cysts present unilaterally or bilaterally, and if between 40 to 59 years, at least 2 cysts in each kidney, and more than 60 years, at least 4 cysts in each kidney. So the father was 32 years old, was having 4 cysts in each kidney, and the paternal grandfather, more than 60 years old, was having multiple cysts. So it does satisfy this criteria. The paternal grandfather needed renal allograft transplant, and hence the asymptomatic 25-year-old uncle was tested, and he was actually, genetic analysis was done, and he was found to be also having a PKD1 variant in a heterozygous state. So now coming back to the index child, do we need to go for genetic analysis in the index child for diagnosis? So I would just like to shed on the guidelines for genetic testing that has been discussed in the International Consensus Statement on the Diagnosis and Management of ADPKD in Children and Young People by Gimple et al. And it was published in Nature Review Nephrology in 2019. That says that in a child under 15 years with a positive family history of ADPKD, sonographic detection of 1 or more kidney cysts is highly suggestive of ADPKD. So positive family history was there. Already the paternal uncle had a PKD1 variant, and this child also had 1 cyst. It has also been found that for PKD1, the diagnostic specificity of more than one cyst on ultrasound is 89% in children less than 5 years, and it increases to 100% in children more than 5 years. So in this index child, we really do not need to go for genetic analysis for confirmation of diagnosis. So what are the other indications? So if the family history is already positive, we need to go for genetic diagnosis in children if they have very early onset disease. For example, if they are presenting in the neonatal age group and they are having hypertension, proteinuria, declining renal function, or children having rapid progression. Because in this case, we need to look at whether there is homozygosity present or there is a compound heterozygous state or contiguous gene deletion syndrome, etc. Also, if there's any patient who is at risk and he wishes to be considered as the living related kidney transplant donor, as was in the paternal uncle, again, suppose the patient is at risk, the patient is asymptomatic, ultrasound is absolutely negative, then also we can go for genetic testing, provided we have counseled the parents and the parents are willing to go for it. And if the family history is unknown and the patient is having ultrasound findings of the kidney, which are suggestive of ADPKD, then also we can go ahead for it. So how do we manage this index child? I won't be elaborating too much on this because already it has been discussed by Dr. Christie in detail. So we need to go for ABPM to check for hypertension yearly. And we have to keep the BP targets less than 75th centile as per this guideline that I just discussed. This child has proteinuria, so we have to start the child on ACE inhibitors, ARBs, which will also help to control the hypertension if it is present. We have to monitor EGFR and various lifestyle interventions, as already Dr. Christie has discussed, and we need to manage complications, if any, and screen for extrarenal manifestations. I would again like to reiterate the fact that as of now, no drug has been proven to retard progression in children with ADPKD. However, off-label use of vasopressin antagonists can be considered at clinician discretion in children who are at high risk of disease progression. So what about the sibling who is 5-year-old? Do we screen him? Yes, clinically we need to go for yearly monitoring with clinical BP measurement and assessment of proteinuria. Now coming to diagnostic testing, either with ultrasound or genetic analysis, there are pros and cons of the same. Pros are that, especially in the teenage years, if we test and if we find them to be positive, it will give us an opportunity to incorporate the lifestyle interventions. Also, in case of rapid progressors, we can start treatment with tolvaptan, although trials are still ongoing, not US FDA approved, to slow down the disease progression. And also we can provide them an opportunity to go for pre-implantation genetic diagnosis. However, cons are that if the results are negative, it doesn't rule out the disease. Also, it is suppose the test comes out to be positive, then it is adding to the psychological burden because we don't have any treatment and the child just comes to know that he has a disease. And it may also jeopardize the ability to secure insurance and gain access to certain professions. If the parents, however, agree, then we have to go for radiological screening with ultrasound. That is good enough. If it is negative, we don't need to repeat it before 3 years of age. And definitely we can go for genetic testing in this child. Since already one variant has been identified, we can simply go for a Sanger sequencing to look for the same variant. Now coming on to the next case. So this is a 9-year-old male child. This child had actually presented in the neonatal age group with antenatally detected enlarged echogenic kidneys without any oligohydramnios. Postnatal ultrasound also showed enlarged echogenic kidneys. The child was normotensive and non-oliguric in the neonatal age group. He did have elevation of serum creatinine in the 1 week. After 1 week, it decreased to 0.6 mg per dl, which was still higher than normal. Subsequently, the child was lost to follow. So at 9 years of age, the child comes to us with hematemesis. On examination, the child has short stature, the child has hypertension, the child has hepatosplenomegaly. Serum creatinine is elevated, liver transaminases are normal. And ultrasound showed that the kidneys are bilaterally enlarged with poor CMD and presence of radially arranged cysts in the medulla. And also the liver is enlarged with increased liver echogenicity and coarse non-homogeneous echotexture. Liver biopsy showed congenital hepatic fibrosis, although this biopsy is not always necessary. The child did not have any other extrarenal manifestations. The child was born to a consanguineously married couple without any family history of renal disease. And the parents who were 35 years and 32 years of age, their ultrasound was normal. So what is the probable diagnosis in this child? So as Dr. Christie had already discussed, this clinical criteria for diagnosis of ARPKD was actually proposed by Zeris et al., which says that there has to be an ultrasound typical of ARPKD in the form of enlarged echogenic kidneys and post-CMD, which was there in this child, and one or more from the following. So absence of renal cyst on ultrasound in both parents if they are more than 40 years. In this child, the parents were less than 40 years of age. Clinical lab or radiographic evidence of hepatic fibrosis, which was there in this child. Hepatic pathology shows characteristic ductal plate abnormalities. So in this child, biopsy did show congenital hepatic fibrosis. Previously affected sibling with pathologically confirmed disease, not there in this child, and parental consanguinity was also present. So genetic diagnosis was sought and a clinical exome sequencing sent that showed that the child harbored PKHD1 variant in a homozygous state that was slightly pathogenic, and parents' Sanger sequencing for the same showed that they were heterozygous for the variant. So it was a case of autosomal recessive polycystic kidney disease. So is the combination of renal cysts and congenital hepatic fibrosis with or without intrahepatic biliary ductal dilatation unique to ARPKD? Although it is most commonly found in ARPKD, but there are a whole lot of other ciliopathies also that can have this hepatorenal fibrocystic syndrome. So these include Jobart and related disorders, Meckel-Gruber syndrome, orofaciodigital syndrome, Bardet-Biedl, and renal hepatic pancreatic dysplasia. All of these syndromes have typical extrarenal manifestations, although not all of these extrarenal manifestations may be present because of variable expressivity, and also not all may be present when you are evaluating the child because many tend to evolve as the child grows. Also, what is the phenotype like in children with ARPKDs who survive beyond the neonatal period? So as Dr. Christie had already told, severe neonatal presentation is seen in majority, in 30 to 50%. But however, with improvement in neonatal intensive care, 75 to 80% may survive in the neonatal period if they do not have very severe pulmonary hypoplasia. So in those children who survive beyond the neonatal period, 40% have been found to have severe dual organ disease, that is severe kidney and hepatic disease. And 20% each can have severe kidney and mild hepatic involvement, mild kidney and severe hepatic involvement, or mild dual organ disease. So a significant proportion will be progressing to ESKD, as has been shown in a study where the 5-year survival is 86%, renal survival, 10 years renal survival is 71%, and 20 years renal survival is 42%. And it has also been seen that those who present in the perinatal age group, they progress to ESKD much earlier than those who present in a non-perinatal period. Those presenting in the perinatal period usually develop ESKD before 18 years of age, as has been seen in a study, whereas those who present in the non-perinatal period usually do so between 15 to 36 years of age. And but after undergoing kidney transplant, a very important determinant of morbidity and mortality are the hepatic complications. Although microscopic evidence of congenital hepatic fibrosis is present at birth in all children, but only 40 to 50% will manifest in the neonatal period, and the rest will develop symptoms anytime between birth to adulthood. And if the child has severe hepatic involvement, for example, the child is having recurrent bacterial cholangitis, or the child is having severe portal hypertension that is not amenable to medical management, we have to consider going for a combined kidney and liver transplant in this children. So moving on to the third case. So this is a 7-day-old male child who had antenatally detected bilateral enlarged echogenic kidneys and oligohydramnios. The child had respiratory distress after birth that required CPAP support. On examination, the child was found to be hypertensive. The child was oliguric. There was no hepatosplenomegaly, and the child also had generalized hypotonia. Serum creatinine was elevated that subsequently started declining. Liver transaminases were normal. And ultrasound showed that the child had bilateral enlarged kidneys with increased echotexture and post-CMD, and small multiple cysts were present bilaterally at the corticomedullary junction. And the liver also showed altered echotexture with few punctate echogenic foci involving the right lobe of liver. The child was born to a consanguineously married couple without any significant family history of renal disease, and the parents' ultrasound were also normal. Both of them were less than 35 years of age. So what can be the diagnosis in this child? So this child had presented with bilateral enlarged kidneys, oligohydramnios, had distress after birth, had elevated serum creatinine, and the liver also showed altered ecotexture, and there was history of consanguinity present. Is it ARPKD? It is satisfying the ultrasound criteria typical of ARPKD, and also the child had history of parental consanguinity. However, we are not sure about the liver involvement. So in this child, we went ahead for a genetic analysis with the help of clinical exome sequencing, and that actually showed the presence of TMEM67 variant in a homozygous state, likely pathogenic, and Sanger sequencing in parents for the same variant showed that they were heterozygous. So this actually is responsible for causing Jobard syndrome. So when we again thoroughly examined the child had generalized hypotonia. The child had persistent tachypnea, although the chest was clear, chest X-ray and USG chest were normal, blood gas was normal. So was it a neurogenic breathing? Could be. Then we went ahead for an MRI brain that showed the characteristic molar tooth sign with deep interpeduncular fossa and vermis hypoplasia, and also the prominent superior cerebellar peduncles. So this was a child with Jobard syndrome. So a little bit about Jobard and related disorders. Classical Jobard syndrome will have cerebellum and brainstem abnormalities, which are seen as molar tooth sign, along with hypotonia and developmental delay. Along with this, other systemic manifestations may or may not be present in various combinations, which include renal cyst, ocular coloboma, retinal dystrophy, occipital encephalocele, polydactyly, hepatic fibrosis, oral hematoma, and endocrine abnormalities. So the Jobard and related disorders, they are caused by variants encompassing 34 genes, 33 out of which are inherited in an autosomal recessive manner, and one, that is orophageal digital syndrome, is inherited in an X-linked recessive manner. And in children who are presenting with classical Jobard syndrome, they may not have the typical truncal ataxia motor delay in the neonatal age group, and in the neonatal period, they may just be having an episodic tachypnea, apnea, and oculomotor apraxia. So this is just a list of all the genes with various combinations of external manifestations that they can have. Our child had TMEM67, which can have coloboma, which can have renal manifestations, hepatic manifestation, polydactyly. Our child did not have polydactyly, and unfortunately, a proper thorough eye evaluation was not done as they did not come for follow-up. And in literature also, certain case reports have been found where homozygous TMEM67 variants can present with a phenotype very similar to ARPK. Now, there are other disorders also that can present with bilateral enlarged echogenic kidneys in the neonatal age group. Obviously, one of them is ARPKD, where the enlarged echogenic kidneys are present with or without radially arranged cysts in the medulla or in the corticomedullary junction. And they may have only congenital hepatic fibrosis in the neonatal age group. Other disorders are mostly they are autosomal recessive. For example, nephronophthisis. Mainly the infantile nephronophthisis can present with bilateral enlarged echogenic kidneys in the neonatal period with similar distribution of cysts. Although the infantile nephronophthisis can have cortical cysts, and they may have extranasal manifestations like situs inversus, cardiac defects, etc. The other is Zellweger syndrome, which obviously can be identified with the help of the external manifestations that they have. Bardet-Biedl syndrome, this also has bilateral enlarged echogenic kidneys with or without cyst. Along with that, some kidney malformations like duplex or horseshoe kidney, solitary kidney, and they will also have some characteristic external manifestations. In the neonatal age group, they can have polydactyly, genital abnormalities, and craniofacial dysmorphism. Other external manifestations may not be discernible in the neonatal period. The other one is a Meckel-Gruber syndrome, which has bilaterally enlarged kidneys and can have polydactyly, occipital encephalocele, and hepatic abnormality. So these, the syndromes that I spoke about, they're mostly autosomal recessive, where family history will not be present. However, two autosomal dominant conditions can also present like this. One is autosomal dominant polycystic kidney disease, and one is the HNF1 beta nephropathy, where in most of the cases, we will get a positive family history. And in ADPKD, the appearance will be very typical, but in the neonatal age group, cortical cysts may or may not be present. And in HNF1 beta nephropathy, along with cortical cyst, other kidney malformations may also be present. In the ADPKD, the external manifestations are very rare in the neonatal age group, whereas in HNF1B nephropathy, in the neonatal age group, we may get external manifestations like genital tract malformations, hypomagnesemia, neonatal cholestasis. And if it is a part of long deletion, like 17q12 deletion, seizures and other neurological manifestations may be present. And this enlarged kidneys may also be a part of cystic renal dysplasias that may be present in an isolated or syndromic manner. So in that case, as Dr. Christie has already discussed, in case of cystic renal dysplasias, the kidneys will tend to be small cystic. Other urological abnormalities may be present, and external manifestations will pertain to the syndromes. So now moving on to case 4. So this is a 6-year-old male child. The child had incidental finding of small cortical cyst in bilateral kidneys when the ultrasound was done due to pain abdomen. And the child also had history of cystic kidney disease in father and paternal grandfather. Hence, the child was referred as a probable case of ATPKD. When we evaluated the child thoroughly, we found that antenatally the child had echogenic kidneys bilaterally, but there was no oligohydramnios. There was no polyuria polydipsia. It was a well-thriving child, normotensive. RFTs were normal. The urine analysis was bland, and electrolytes showed that the child had hypomagnesemia. An ultrasound showed that the child had normal sized kidneys at 6 years of age with multiple small cortical cysts bilaterally. There was no history of consanguinity. The father, who was 35 years old, had cystic kidneys along with stage 2 CKD, and he had type 2 diabetes diagnosed 3 years back. The paternal grandfather had cystic kidneys, stage 5 CKD, and he was on intermittent hemodialysis when he died at 53 years of age, and he was also known diabetic. So, what can be the probable diagnosis? This is a child we are talking about who has small cortical cyst in bilateral kidneys, which are normal in size, and no history of polyuria, polydipsia, RFTs are normal, only hypomagnesemia is there. And there is significant family history, probably indicating an autosomal dominant pattern where father and paternal grandfather has both cystic kidneys as well as diabetes. So probably we are dealing with HNF1 beta associated cystic kidney disease. And HNF1 beta cystic kidney disease can have a whole lot of external manifestations, as has already been discussed by Dr. Christie, so I won't be talking about this in detail. And there are other autosomal dominant polycystic kidney, autosomal dominant cystic kidney diseases also that we should be aware of. One of them is definitely ADPKD. The other one is the ADPKD group, which Dr. Christie already discussed. Most of them will be having normal to small size kidneys later on, except for HNF1 beta. And most of them will be having poor CMD, small medullary cysts or cyst along the corticomedullary junction, although HNF1 beta can have cortical cysts. And they almost all of them, barring the MUC1 one, will have hyperuricemia and early onset gout in the late childhood and adolescence years. And depending on the genetic mutation, they can have other external manifestations also. In case of von Hippel-Lindau, also the child can have multiple bilateral renal cysts. And we can identify these children with the help of various extrarenal anomalies. Usually in childhood, we will get retinal hemangioma, pheochromocytoma, and clear cell RCC if any. In tuberous sclerosis complex also, we can get multiple and bilateral cortical cysts with or without medullary cysts and angiomyolipoma. Oncocytoma and renal cell carcinoma are rare in the pediatric age group. And again, in this case, the various extrarenal manifestations typical of TSC can help us to clinch the diagnosis. However, in case of TSC, there is an entity called the TSC-PKD contiguous gene deletion syndrome, in which a significant length of the chromosome gets deleted that encompasses both the TSC as well as the PKD gene. And in that case, the child can present in the neonatal age group or in infancy with rapidly progressive bilateral polycystic kidneys. And this may actually precede the neurological and the dermatological manifestations of TSC. So in that case, initially making a diagnosis of TSC may be difficult. Other syndromes are there, like branchioautorenal syndrome, renal coloboma syndrome, Alagille syndrome, and big one cystic renal dysplasia, which are also inherited in an autosomal dominant manner, but these are usually cystic renal dysplasias, and they can have associated CACOTs, and they can have characteristic extrarenal malformations. So how do we confirm the diagnosis in this child? We have to confirm by genetic analysis. We can go for a next generation sequencing in the form of targeted exome sequencing, clinical or whole exome sequencing. But however, if the child is having a 17q12 deletion, it may be missed on the exome sequencing. And in that case, we may have to go for an MLPA or a chromosomal microarray. So take-home messages are that cystic kidney diseases in children are mostly inherited, either as part of ciliopathy or as part of cystic renal dysplasia, and they're much less likely to be simple renal cyst or acquired cyst. Radiological appearance of the kidneys, distribution and size of the cysts in the kidneys, along with external manifestations and family history, will help to narrow down on the diagnosis. But due to considerable phenotypic variability and overlap, and due to lack of genotype-phenotype correlation, we have to seek confirmation through genetic analysis. And management is often multidisciplinary. Therapeutic modalities to prevent cyst progression are yet to be approved in children. Thank you.
Thank you so much, Devina. I think you complemented Christy's presentation very well by giving a very management approach through your boxes and checklists. I'll now request Dr. Pankaj to take some questions ahead. I think the participants have all been just listening rapidly. No
Yeah.
one has typed any questions.
No,
And some
there
of
was a
them were
question. Yeah, there are the question. I think she can take those questions and discuss, because I answered one of them, and one was wrongly clicked by me. So, so there is a question saying any relation of presence or absence of hepatic cyst with the prognosis of ADPKD. And Devlina, could you be answering this question?
Yeah, actually, hepatic cysts in case of ADPKD due to PKD1, PKD2, they're pretty rare in children, but there is an entity called autosomal dominant polycystic liver disease, which is mainly caused by the DNA JB11 and also the GANAP mutations, mainly the GANAP. In that case, mainly the cyst will be there in the liver, and the kidney involvement will be much less severe. So if we are getting something like we are getting cyst in the liver, cyst in the kidney in an autosomal dominant manner, and if the genetic analysis is showing DNA, GANAP and DNA B11, so maybe the kidney phenotype will tend to be less severe.
Thank you. And there is one question for Christy. I think Christy showed that there is hyponatremia in ARPKD. So somebody has asked, what is the reason for this euvolemic hyponatremia?
You're mute, Christy.
Christy, yeah.
Headphone on.
Am I audible now?
Yeah.
Okay. It's due to water retention, and it's euvolemic hyponatremia. The problem is at the collecting tubule. The tubular dysfunction leads to water retention and euvolemic hyponatremia. And the treatment is also, if it is severe, we can concentrate the feeds.
So, Dr. Pankaj, which is the commonest one in the clinical that our participants might come across in your experience? Which are the commonest conditions in these cystic diseases?
So if you are looking at overall all the cystic kidney disease, then the ADPKD would still be the commonest, while its presentation in childhood is uncommon.
Yeah.
On the other hand, ARPKD is rarer, but then what you see in childhood very often could be ARPKD.
Yeah.
We also see the whole nephronosis spectrum,
Yes.
and in a tertiary care hospital, we tend to see them very often.
Typically, the nephronosis tend to come with anemia, short stature, and then you might find the eye retinitis pigmentosa a part of a syndromic. Very true. Any experience, Christy, at your center, Devlina at your center?
So actually, my thesis was on cystic kidney disease, and what we have found is almost two-thirds was constituted by nephronophthosis spectrum disorders, and then the frequency of ARPKD and ADPKD was almost similar.
Yeah, the childhood. Very true. There are, Pankaj, there are a couple of more questions.
Yes, there is the same question written twice, and Christy, could you take that question? ADTKD will have all features of tubular dysfunction like hyperuricemia, amino aciduria, glycosuria, etc. He's asking this.
Yeah, Christy, I think you had mentioned about how hyperuricemia is much because of the location where you really get those cystic dilatations, right?
Usually we expect amino aciduria and glucosuria in proximal tubular dysfunction. And it's ADTKD, it's more like it's endotubular may get affected, and the distal tubule, it's collecting that, but distal part of the tubule is more affected. We expect hyperuricemia, hypermagnesemia. I don't think we are expecting glucosuria or amino aciduria.
Correct. Very true. So are we done, Dr. Pankaj? Should we hand back over?
Yeah, it seems like we are already done, and no more questions.
Yeah.
So
So it's been a very enjoyable 6 weeks.
yes, absolutely. Absolutely. We really enjoyed the all the sessions, all the webinars.
So Jitendra, would you like to take it over again?
Yes, ma'am. Thank you, ma'am. Thank you, sir. Thank you, Dr. Christie and Deblina, for nice interaction around cystic kidney disease. Mamita, can you begin with the post-test, please?
Yes, sir. Definitely, sir. So I'm launching the first poll of today's session. Twenty seconds left. 15 seconds left. Okay, sir. So I'm ending the poll and moving to the next poll. 15 seconds left. Okay. Okay, so moving to the next poll. Okay. 20 seconds left. 10 seconds left. 'Okay, so I'm ending the poll and poll of today's session. So 25 seconds left. 10 seconds left. 'Okay, so I'm ending the poll and moving to the next poll. 20 seconds left. 50. Okay. So I'm ending the poll. Moving to the next poll. 20 seconds left. 'I think so. Next, moving to the next poll. 15 seconds left. 'Ending the poll and moving to the second last poll of today's session. 3 seconds left. Okay, so I'm ending the phone and moving to the second last phone. 5 seconds left. Moving to the last poll of today's session. Sir, 15 seconds left. Sir, we are completing all the polls. Sir. Thank you. Jitendra sir, shall I share
Yeah.
the result?
No. Just
Okay,
a
okay.
sec.
Sir. Oh,
Am I audible?
yes, sir, you are audible.
Yeah. So, for participant, just an announcement, we had to change some of the dates of the, webinar of the last module because of some unavoidable circumstances and some speakers are not available. So, our next webinar would be on this Sunday on 17 September, and we'll have one more webinar on next Friday. Then next Sunday and then 29th we'll be finishing with our final webinar. So I've shared this webinar modified schedule on WhatsApp, and I'll mail all of you this modified schedule. So our I'm repeating once again, our next webinar would be on Sunday, 17 September, 7 p.m. So we'll be beginning with the final module, that is chronic kidney disease. So thank you once again for joining us today. With that, we'll be ending today's webinar.
So much to all of you, and with all due permission, I'm closing the session for today and looking forward to hosting you again. Thank you so much to everyone. Bye. Good night.